Hello friends, today we'll learn about comprehensive transesophageal echocardiography views. There are 20 standard views as published by Shane Weiss and co-workers in the year 1999. American Society of Echocardiographers and Society of Cardiovascular Anesthesia adopted them as guidelines for performing transesophageal echocardiography. In addition to these standard views, there are many described by several authors. Usually, the transesophageal echocardiography probe is inserted, and one could start the views from upper esophageal to transgastric or vice versa. It is said that the transgastric view being done first and the assessment done as the probe is being withdrawn reduces the movement of the probe in the esophagus, and therefore it is less traumatic and it's said to save time. It is a good idea to have the electrocardiogram connected to the monitor while doing the echocardiography, because eyeballing the phases of cardiac cycle is not very accurate, and it is important to have diastole and systole identified using electrocardiogram. And at the Authors Institute, we do the deep transgastric first and do the rest of the assessment as we withdraw the probe. And the uh, upper esophageal views are secured between 20 to 25 centimeters, and mid esophageal between 30 to 40, and transgastric between 40 and 45. And we have to remember that there is no one method of doing echocardiography. Although these 20 standard views are a good guide for a novice echocardiographer, one could also conduct focused echocardiography where an object of interest is assessed and the others are not considered at the time of the examination. Deep transgastric view, which is shown here, is obtained by advancing the probe deep into the stomach to a distance of about 40 to 45 centimeters from the incisors. The probe is then antiflexed and rotated to the right, which enables us to interpret the deep transgastric view. This is sometimes difficult to view, and frequent manipulation of the probe, echocardiographer could learn to obtain this view easily. In this view, the aortic valve is located in the far field with a left ventricular outflow tract directed away from the transducer. The spectral Doppler quantification of the left ventricular outflow tract and the aortic valve is usually possible in this view in most patients. If not, transgastric long axis can be used. Normal peak aortic flow velocity is between 1.4 to 2.2 meters per second. Normal left ventricular outflow velocity is less than 1.2 meters per second. This is an important view to estimate the isovolemic relaxation time, or IVRT, by aiming the continuous wave Doppler beam through the mitral valve and aortic valve simultaneously. The time from aortic valve closure to the opening of the mitral valve is the isovolemic relaxation time, and the normal value is about 90 milliseconds. Now we go to the uh, transgastric mid-papillary short axis view. Here the probe is advanced into the stomach to obtain the transgastric view first, and then at about 38 to 42 centimeters of probe insertion, the probe is antiflexed, withdrawn gently. The important structure to visualize in this view are the left ventricular walls, anterior, inferior, septal and lateral walls. Additionally, the cavity, in addition to the posterior medial and the anterolateral papillary muscles, may also be interrogated. If papillary muscles are not visible in this view, the probe is too distal. In order to visualize the papillary muscles, one should withdraw the probe further. Once the depth of the probe is appropriate, flexion is adjusted to bring the anterolateral papillary muscle into the correct position. This is conventionally used to assess the hemodynamic status such as hypovolemia, and it is an important view for a novice echocardiographer to assess the patient's volume status. This is also an excellent view to assess the left ventricular walls, that is anterior, inferior, septal and lateral walls, and accordingly decide which of the coronary arteries well revascularized or recently obstructed. And left ventricular systolic function, left ventricular volume, and segmental wall motion abnormalities can be assessed in this view. Next, we go to the transgastric right ventricular inflow-outflow view. From the mid-papillary view, by rotating the probe clockwise to the right or to the right, brings the right ventricular into the center of the screen. From this position, multiplane angle is increased to 120 degrees to secure the transgastric right ventricular inflow view. This view is commonly used to study the tricuspid valve pathology, right ventricular systolic function, and to measure the tricuspid annular plane systolic excursion, or TAPSE, to assess the right ventricular systolic function. From this view, we go to the transgastric two-chamber view. From the transgastric mid-short axis view, multiplane angle is increased to 90 degrees and the transgastric two-chamber view is obtained, which provides a long axis view of the left ventricle with the apex to the left of the display and the mitral valve to the right. The diagnostic use of this view is to analyze regional wall motion and also evaluate the subvalvular apparatus in mitral valve. The apex of the left ventricle is often not visible as the transgastric two-chamber view. It is useful for examining the chordae tendineae, which are perpendicular to the ultrasound beam. Chordae to the anterolateral papillary muscles are at the bottom of the image, and those to the posteromedial papillary muscles are at top. Prior to performing mitral valve repairs, when the chordae are tethered for caudal lengthening, this view is an excellent one to measure the additional length that is required. From this view, we go to transgastric aortic valve long axis view. From this two-chamber view, rotation of the imaging plan to 120 to 140 degrees. It varies at times from 110 to 132, enables us to visualize the anterior structure of the left ventricular outflow tract and the aortic valve. This view is useful for Doppler evaluation of the aortic valve. In this view, Doppler alignment is at 0 degrees, therefore the accurate estimation of the flow across the left ventricular outflow tract and the aortic valve could be estimated well. This is an important alternate view for aortic valve assessment when valve replacement has been done. The next view is the transgastric basal view. This is obtained by withdrawing the probe from the mid-papillary view until the mitral valve appears, which exhibits the 6 basal segments of the left ventricle. In this view, the anterolateral commissure is in the far field and the posteromedial commissure is in the near field. The anterior leaflet is to the left of the image and the posterior leaflet to the right. This view is useful for identifying leaflet abnormalities, localizing of the origin of the mitral regurgitation jet, and evaluating the mitral valve area planimetry. The next view is the mid-esophageal 4-chamber view, which is one of the important landmark views wherein many of the structures of the heart could be seen. These views are secured at a distance of 29 to 33 centimeters from incisors, with an imaging angle between 0 to 20 degrees, and the transesophageal echo probe is advanced to the mitral valve level. The mid-esophageal 4-chamber view is obtained with some degree of retroflexion. This view allows visualization of all chambers of the heart. The structures to observe here are the left atrium, left ventricle, right atrium, right ventricle, mitral and the tricuspid valve, and the basal, mid and apical segments of the anterolateral and inferoseptal wall. To evaluate the right heart, the probe is turned to the right until the tricuspid valve is displayed. The depth is adjusted to include the tricuspid annulus and the right ventricular apex. In this view, apical portion of the anterior right ventricular free wall is to the right of the display and the basal anterior free wall is to the left. The left ventricular outflow tract and the aortic valve is displayed in a so-called 5-chamber view, which is not one of the conventional views. It is obtained by anteflexion and slight withdrawal of the probe. Evaluation of the chamber size and function, valvular function of both mitral and tricuspid valve regional wall motion abnormalities of the septal and lateral walls of the left ventricle, de-airing after cardiopulmonary bypass could be performed in these views. A combination of the 4-chamber and the 2-chamber views are necessary for measurement of ejection fraction of the left ventricle. For measurement of the ejection fraction by modified Simpson's method, these views are important. The next view is the mid-esophageal mitral commissural view. From the 4-chamber view, by increasing the multiplane angle about 60 to 70 degrees, the mitral commissural view is obtained. This view is important to study the mitral leaflets since both the commissures, posterior-medial and anterior-medial, are visualized here. From the right to left, the segments of the mitral leaflets are P1, A2 and P3. The leaflet pathology, left ventricular systolic function, can be assessed in this. Conventionally, for assessment of mitral valve, only this view has to be used. The next view is the mid-esophageal 2-chamber view. From the mitral commissural view, by increasing the multiplane angle to 90 degrees, the mid-esophageal 2-chamber view is obtained. This view is identified by the presence of left atrial appendage, and this view is useful in evaluating the left ventricular systolic function, mitral valve and ventricular apex pathology, detecting the presence of thrombus in the left atrial appendage. The segment of the anterior mitral leaflets are seen in this view. The segmental wall motion abnormalities of the basal, mid and apical segments of the inferior and anterior wall are detected in this view. Mid-esophageal aortic valve long axis view is an important view wherein the left ventricular outflow tract could be studied. Mid-esophageal long axis is obtained by further rotating the multiplane angle to 110 to 130 degrees, rotating the probe and withdrawing the probe to obtain the aortic valve may be necessary sometimes to optimize this image. In this view, left ventricular outflow tract, aortic valve, aortic root and proximal ascending aorta are seen. The primary aim of using this view is to evaluate the aortic valve function. Proximal ascending aorta should be inspected for calcification, aneurysm, dissection flap and atherosmatous plaque. An important limitation of this view is that the distal ascending aorta cannot be visualized because of the interposition of the left main bronchus between the esophagus and the ascending aorta. The measurement of the aortic root required during the transapical aortic valve replacement or aortic valve repair are obtained in this view. This is also an excellent view to observe the systolic anterior motion of the mitral valve. One should appreciate the various anatomical parts of the ascending aorta, such as the aortic valve, sinus of Valsalva, sinotubular junction or STJ, and the ascending aorta in this view. Various measurements that are required for the cardiothoracic surgeons for the aortic valve repair or sometimes replacement are done in this view. Dissection of the ascending aorta may be well delineated in this view. The next view is the mid-esophageal long axis, wherein the flow across the mitral valve could be assessed well, and this is obtained by withdrawing the probe by a centimeter or two, wherein the left ventricular outflow tract goes out of view. The mid-esophageal bicaval view is obtained by turning the probe further to the patient's right from the aortic valve long axis view and reducing the multiplane angle by about 90 to 100 degrees. The important structures in this view are the left atrium, right atrium, superior vena cava, inferior vena cava, interatrial septum, right atrial appendage. At a multiplane angle at about 135 degrees to the modified bicaval is used. In this view, tricuspid valve pathology and the coronary sinus could be evaluated. Interatrial septum could be observed for atrial septal defect, abnormalities, patent foramen ovale, elevated atrial pressure by noting the deviation of the interatrial septum to one side of the atrium or the other. By applying color Doppler to the interatrial septum, low velocity flow could through an atrial septal defect or patent foramen ovale may be detected by decreasing the Nyquist limit to about 30 cm per second. Yet another way to detect the right to left shunting is by injecting agitated saline into the right atrium as the positive pressure is released and detecting the air bubbles in the left atrium. The appearance of contrast in the left atrium is less than 5 cardiac cycles indicates the presence of an interatrial septum, the intratrial shunt. This view is also used prior to instituting a left ventricular assist device to detect the presence of patent foramen ovale. The next view is the midesophageal right ventricular inflow-outflow view. This view is obtained from the midesophageal aortic valve long axis by reducing the multiplane angle to about 70 degrees, keeping the probe rotated to the right or in clockwise direction. This view visualizes the tricuspid valve, right ventricular outflow tract, and the proximal pulmonary artery. This utility of the view are to assess the right ventricle, right ventricular outflow tract pathology, and to evaluate the pulmonary artery. This view is superior to the midesophageal four-chamber view for Doppler interrogation of tricuspid valve. This view also may be used when difficulty in passing the Swan-Ganz catheter into the pulmonary artery at times. The midesophageal aortic valve short axis view is obtained by reducing the imaging plane to approximately 30 to 40 degrees from the right ventricular inflow-outflow view until all the three cusps of the aortic valve are seen to obtain the midesophageal aortic valve short axis view. The cusp adjustment to the atrial septum is the non-coronary cusp. The cusp in the far field is the right coronary cusp, and the remaining one is the left coronary cusp. At times, one can visualize the left coronary artery arising from the left coronary cusp. This utility of this view are to define the morphology of the aortic valve, whether it is bicuspid, tricuspid, or unicuspid. Also to determine the presence of aortic stenosis by planimetry of the aortic valve, to assess the severity of the aortic regurgitation by calculating the ratio of area of the regurgitation jet to the cross-sectional area of the left ventricular outflow tract. The Mercedes-Benz sign seen here serves as a landmark to novice echocardiographers. Midesophageal ascending aorta long axis view is obtained by withdrawing the transesophageal echocardiography probe from the midesophageal four-chamber view until the midesophageal five-chamber view develops. This process of withdrawing is continued until the aortic valve tends to disappear from the center of the image. Then the probe is antiflexed to secure the ascending aortic short axis. In this view, main images that are seen are the ascending aorta, and to the left of the main pulmonary artery and the artery ascending aorta, the superior vena cava, are seen in the short axis. The aim of this view are to diagnose pulmonary embolism, aneurysm of the ascending aorta, confirming the position of Swan-Ganz catheter, rotating the multiplane angle by about 90 degrees. The midesophageal ascending aortic long axis view is obtained. The right pulmonary artery is seen as a circular image near the far field and the ascending aorta in the far field. This is an important view for evaluation of the dissections and aneurysm of the aorta. Artifacts are commonly encountered with the ascending aorta in this view. At the mid-esophageal level, from the four-chamber view, rotating the probe posteriorly in an anti-clockwise direction to the left, optimizing the depth to 4 to 6 centimeters results in a descending aortic short axis view. This is an important view to evaluate many diagnostic issues like the presence of the atheromatous plaque, dissection, left pleural effusion, and the position of the intra-aortic balloon pump. The presence of pathological lesions in the descending aortic view may necessitate additional procedures such as epi-aortic scanning of the distal ascending aorta and proximal aortic arch, especially in presence of atheromatous plaque, to alter the surgical plan. Rotating the multiplane angle to about 90 degrees, one can obtain the descending aorta long axis view. This view is used to assess the severity of the aortic regurgitation by analysis of spectral Doppler at the proximal and the distal end of the descending aorta, demonstrating the presence of holodiastolic flow reversal. And the withdrawal of the probe further to about 20 to 25 centimeters, we obtain the upper esophageal views. And these views are necessary to see the aorta, the neck vessels, innominate artery, subclavian artery, and also internal mammary artery. By increasing the multiplane angle, one can obtain the aortic arch long axis, and in this short axis view, images of the main pulmonary artery and pulmonary vein are obtained in most certain patients in the left side of the display. The origin of the branches of the aortic arch are seen to the right of the display. The Doppler evaluation of the pulmonary artery could be done in this view. Origin of the left subclavian, left common carotid, brachiocephalic artery can be visualized using minimal rotation of the transesophageal echocardiography probe. Thank you.